I'm Dr. Miriam Bornhorst from Lurie Children's Hospital of Chicago, Northwestern University, and I'm going to talk today about the application of optical genome mapping for pediatric brain tumors, solving challenging cases. I don't have any disclosures relevant to this presentation, but I do need to let you know that I'm on the external advisory board for a registry trial through Alexion Pharmaceuticals. So many years of research have shown us that structural variants are quite important in pediatric brain tumors. The most common would be fusions, as they can be targeted with different types of therapies, but deletions and other types of structural variants are also important, not only for therapy, but also for prognosis. So on the side here, I've actually put together all of the different pediatric brain tumors based on their WHO classification, and then the molecular alteration that are common in these types of tumors, and then possible therapeutic options. And you can see with the bolded structural variants here that there are quite a few that are not only important for diagnosis, but also important for therapeutics for pediatric brain tumors. Also important, recently we've had several molecular initiatives, particularly the COG-MCI initiative, that has allowed for frozen tissue to be saved and preserved for analysis, which is really important for optical genome mapping, as previously most of the tissue we had available was for FFPE, which also makes pediatric brain tumors a prime type of tumor to study using this technique. So in my laboratory so far, I've looked at about 100 pediatric central nervous system and peripheral nervous system samples using optical genome mapping, really to try to look at the structural variant variations, not only things that we already know, but also new things that we can potentially learn more about the tumor with. Most of the tumors that I've used so far have been supratentorial in location, but I'm moving down to the infratentorial tumors as well. And you can see a list there of all the different types of tumors that I've analyzed so far. There's a good variety there, including those, the PNS, plexiform neurofibromas, and MPNSTs. The samples that I've used have been diagnostic, recurrent, and postmortem samples. This is just showing you a screenshot of sort of an example of what the samples would look like after analysis. And I think what's important here is that the coverage in the N50 scores were sufficient for structural variant and CNV analysis for a majority of the samples that I analyzed. There were only a few low-grade gliomas that failed analysis, which is really exciting because most of these tumors are amenable to optical genome mapping. You can see on the side there that the average N50 greater than 150 kilobase pairs was 246. The average map rate was about 78%, and our effective coverage average was about 576x, which is really good coverage for these tumors. The preliminary analysis of this cohort indicates that there's approximately 20% increase in detection of pathogenic variants that were previously not identified by standard of care. And I haven't shown all of the examples here, but this is a table showing some of what we saw. So the tumor diagnosis, the pertinent molecular findings that were found on clinical testing. So it was anything from negative to a fusion that was most suggestive of something, or just mutations alone, but not necessarily finding the structural variant. On the third column there, you can see the pertinent molecular findings that I found on optical genome mapping. So in the first one, we found a NUT-M1, ZNF532 fusion, and this may impact treatment response. The ependymoma that was most suggestive of a ZFTA rela fusion actually had, per our analysis, a ZFTA NCOA1 fusion, which is a little bit different than the rela fusions and may actually impact treatment response as well as prognosis. The high-grade glioma had a deletion that we detected that was similar to the clinical testing, but we also found an NTRK2 fusion in this, which may have been good for targeted NTRK inhibitor therapy. And then we also looked at a DIG that had negative molecular testing, but we did find a BRAF fusion, which could have potentially indicated MEK inhibitor therapy for this patient as well. For our grade 2 diffuse glioma, we actually found a very interesting ATRX structural variant. So there's multiple different structural variants in that particular region impacting the ATRX function. So even though on IHC, they were able to find that there was loss of ATRX, on our research analysis, we were able to see that there was a structural variant in that area. And then for the schwannoma, we found a very interesting SH3 PDX2A fusion that may indicate that this patient has an LZTR1 associated schwannomatosis. So just to look at some of these a little bit more in detail, this is a 1.5-year-old with a supratentorial tumor with pathology consistent with an embryonal tumor, and it had some rhabdoid and epithelial features. So that's what the diagnosis was at that time. And this is just showing the MRI and the pathology. And when we did our optical genome mapping, this was the patient that had that NUT-M1 ZNF532 fusion, which really is a new subtype of embryonal tumor that was not previously described. This fusion has been seen in other types of head and neck tumors that have very similar pathological features, but had not been described in a brain tumor before. So you can see on here the circus plot. So there's a very complicated sort of rearrangement between chromosomes 18, 15, and 12. And then on the side there, we sort of broke down the different chromosomes. And ultimately, through all the different rearrangements, there is a fusion between the ZNF532 and the NUT-M1 proteins. We did do some testing to show that this was impacting the function of the NUT-M1 protein, which would be very important for tumor growth. This is another example or another patient where we have an adult patient with 4 distinct unilateral schwannomas. And on the side there, you can see the MRI 3 of the different schwannomas. The 4th one we weren't able to capture by imaging very well. And then you can see the pathology was very consistent with schwannomas as well. And so when we did our initial NGS, MLPA and LOH testing, we found that tumor A and tumor B, so we had 2 of the tumors that were resected, had a shared NF2 mutation, which you can see at the top there with an allele fraction between 14 and 25%. And then they had distinct separate NF2 mutations. Tumor A had an NF2 mutation that had an allele fraction of 33%, which would be consistent with the second hit. But then tumor B had 2 NF2 mutations that had very low allele fraction. So not really enough for us to call it the second hit. So we did do MLPA to look for copy number loss, and that was negative in both. But LOH for tumor B was positive, and you can see on the bottom there, all of the red boxes are showing where it was positive for LOH, which made us suspect that there probably was copy number loss that wasn't detected on MLPA. So we went ahead and we looked or used optical genome mapping to look at chromosome 22. And you can see sort of on the circus plot there is copy number loss as well as in the genome browser. And chromosome 22 had copy number loss, but it was at a mosaic level. So we estimated it to be about 12.5%, which is probably why it was not detected by MLPA. But it does give us enough cause to call this the second hit for that tumor. And so we were able to confirm that this patient probably had a mosaic type NF2. So with this results, we decided to look a little bit more into tumor mosaicism because we've been using optical genome mapping to find structural variants, but this mosaicism aspect of it, I think, is very important because we have to be able to find structural variants even if they don't have a high allele fraction. So mosaicism is often defined as the heterogeneity of the tumor, and this is a really great picture showing mosaicism and where you go from a normal cell that then has a tumor population that then, you can have a second tumor population and multiple subclones of mutations. And each one of these populations contributes to the tumor. So each one of them is actually important in terms of therapeutics. So why is it important for us to detect structural variants that are at a mosaic level? So these are just a few of the reasons. It not only allows us to discover other variants that may be associated with recurrence risk, but it can expand potentially our therapeutic options. It may help us really identify different types of cell populations where you might need to use different therapies to target those populations. And then, of course, physicians or patients may be falsely reassured with negative results. So if you have a CDKN2AB deletion, for example, in your tumor, but it doesn't come back as positive, that's not necessarily good because, physicians will think, oh, this is going to be fine, but that patient is a higher risk for recurrence. It also will allow for analysis of all tumor samples, and this is most important if there's a low tumor purity. So right now for low-grade gliomas, especially if we don't have a good enough tumor purity, they can't be analyzed. Sequencing is not possible, but if we were able to detect mosaic structural variants, at least for those BRAF fusions, this would be very helpful. And this is just showing 4 examples of low-grade gliomas that we've pulled in that kind of highlights that importance. So all of these low-grade gliomas by clinical testing did not have a BRAF fusion, but when we looked at them through optical genome mapping, we were able to find a BRAF fusion at a mosaic level in the 4 different tumors. So it's important, again, to be able to identify these fusions, even if they're at a low level. This is also another example of a tumor that we looked at, really just focusing on mosaicism. It's a patient who had a neurofibroma that had transformed into an MPNST, but when we sent it off for clinical testing, it did not have any of the genomic signatures of an MPNST. So we went ahead and did optical genome mapping, and on the optical genome mapping, not only did we find the MTAP CDKN2AB deletion, which is important for that diagnosis, but we also found an MSH2 fusion between chromosome 2, there was a fusion between chromosome 2 and chromosome 13 that impacted the MSH2 gene function, which likely made this a little bit more aggressive of a tumor. So in conclusion, optical genome mapping of pediatric brain tumors is an effective method for the identification of clinically relevant structural variants, some of which are not identified with other clinical sequencing methods. As we showed, about 20% actually can be identified with that were not found in clinical sequencing methods. This method can be used to develop structural or variant tumor maps, which will really help with diagnostic, prognostic, and therapeutic management of patients. And future studies will expand testing to a larger cohort of samples to better understand the full spectrum of the structural variants and begin clinical analysis to determine the effect of these structural variants on response to treatment and prognosis. So I'd like to acknowledge members of my laboratory and collaborators that I've worked with to really make this project possible. Heike Barsegan and Surajit Bhattacharya, especially as they have helped not only with the data sort of analysis, but also the application of this in terms of trying to figure out what everything means. Deandra Spencer, who's also helped a lot on the lab side, Yulong Fu, and then Augustine Denise and Dr. Nazarian, who've helped with acquiring the samples. I also have my funding sources on here, and I especially want to say thank you to the patients and families who donated samples for this project, and to Bionano Genomics for inviting me to come here to talk today. Thank you.